So a slow start there, I apologize. I'm Dr. Mark Schwartz, and I'm a psychologist. And I'm going to be talking to you about sexual desire and eating disorders. And this is a topic which has long roots, which is that I began my work many years ago with Masters and Johnson, working in sex therapy and marital therapy. And then eventually turned to working with sexual trauma and sexual compulsivity, and found that a subset of clients had eating disorders and they weren't being treated adequately. So I combined my interest in sexuality and relationships with eating disorders, and this is the first time I've really talked on this topic. Now I'll move on to talking about sexual desire. First of all, let's define the term, which is that sexual desire refers to people's initiatory behavior for sexual interplay, and it can include masturbation or sexual activity with a partner. And it's contrasted with sexual arousal, which is a physiological responsiveness. And you can imagine that there are very different factors that affect sexual desire than sexual arousal. Many people are really highly turned on, but they're terrified of sex. And so many years ago, Helen Singer Kaplan wrote a book on treating desire phase disorders, and she began to talk about the variety of psychiatric disorders and psychological factors that can affect sexual desire or initiatory behavior. Certainly eating disorder is one of those, and we find that really all the patients have some sort of issues related to sexual desire. Either it's too little or too much or both, and it kind of reflects their attachment system. Sometimes in their attachment system they tend to be more preoccupied, where there's a lot of anxiety in finding a partner, and so during the courtship phase in particular they'll find themselves pretty highly sexually aroused, but then once they find a partner they get terrified and they pull back into a dismissive attachment pattern, and what you find then is that their sexual desire decreases. So what I wanted to do first is talk to you a little bit about eating disorders and how it interacts with sexuality. And I give you this first quote by Catherine Zerbe, where she says that a substantial psychiatric impairment across categories found in over 200 studies of outcome of eating disorders. And they find that psychological adjustment, 50% or more of the patients are suggested by the refractory psychosocial problems of the anorexic or bulimic patient. They require more interventions for more comorbidities. And then list them. And what I would say is that that's been our experience. We can get the eating disorder under control, both the anorexia in terms of refeeding or the bulimia in terms of binging and purging. But in order to maintain that control, one has to anticipate what some of the other difficulties they may be having are, or what the comorbidities are. Clearly, if they're obsessive compulsive, if you don't treat the obsessive compulsive disorder, you're going to get symptom remission. Well, similarly, with sexual compulsivity, many times the client won't tell you that as they get under control of the eating disorder, the sexual compulsive behavior increases dramatically. And so we find many of our clients getting interested in cybersex and starting to contact potential partners on the internet, or they go home and they have low sexual desire, or they find themselves with a partner just simply because they want someone to love them, and then feel like they're being raped again because when they get into the bedroom they find themselves a part of self which has been traumatized seems to come out. And so it's one of the fastest relapse factors in the first 3 months after they leave. So this is really an important issue, and one that's really not been discussed much in the field. So I wanted to start with some normative data just to give us some idea and some frame of reference for what we're talking about, which is that let's just pick an item such as masturbation. In the anorexic group, in this one study that has been done, they find that 34% of the clients have masturbated, whereas if you look at controls, it's closer to 70%. So about a third of the clients are going to have issues around masturbation, and oftentimes therapists won't bridge this because they'll see they need refeeding and think that that's pretty far down the line. But obviously sexuality is one of the factors that contribute to the eating disorder in the first place. general sexual contacts, you see 26% have had some contact, whereas a whopping 95% of control groups. So this group does seem to be highly sexually inhibited, and coitus equally low. And I just thought I'd give you some generic factors in the population, which is that a larger sample of female women, 88% masturbate to the mean age of 34, and that does classify as some sort of a revolution if you think of it from the 1950s. But in actuality, there's still a fairly high epidemic of women in our culture who have sexual difficulties, because, as you can see, only 50% of adult women masturbate to orgasm in Kinsey's work, and a whopping 87% of adult women still have guilt about masturbation. So I think it's helpful just to know something about the normative data, because this population is like the normative data, only more severe, obviously. Also, just if you want some idea of normative data, 63% of women report arousal and orgasm problems when they're going to a gynecologist, whereas 85% reported that they were satisfied with their sexual relationships. So what we're seeing in an endemic level across our culture are women who are relatively satisfied with their sexual lives, but a high percentage of them really having major difficulties with arousal and orgasm. And I think that for some reason there's a lack of understanding of what's going on endemically among women in our culture. Now, a more precise way of looking at this is to use an inventory. So the Derogata Sexual Functioning Inventory is the one which is most widely used. And again, I think these data are helpful. You see anorexics in the first column, and anorexic bulimics in the second column, and then bulimics in the third column. And what you see in this population are some fairly high indicators of difficulty, but the ones that are checked are the ones that are most clinically and statistically significant. And so the real differences between anorexics and bulimics are in their sexual drive, which is much lower, and their sexual fantasy patterns, which are much lower as compared to the bulimics. And of course, gender role kind of confusion. So I think that would sort of give you some normative data. And then with regard to having masturbated, only 24% of those diagnosed with anorexia indicated that they had had experience with masturbation. 51% of bulimics said they had masturbated. And the severity of caloric restriction was inversely related to having masturbated. So, I mean, obviously, low weight means low desire, means low masturbation, but the frequency in this population is notably low. And so as they begin the refeeding and they begin to get their appetite back, sometimes their sexual arousal patterns scare them. And that's one of the reasons why they end up lapsing or relapsing, is because they, in terms of affect regulation, they do not like the feelings of sexual desire in their body any more than they like the feelings of hunger or fullness in their body. So as we think of proprioceptive cues and people being able to be aware of their proprioceptive cues, I think it's important to ask questions about feelings in their body. And as they begin to get less dissociated and more mindful, one of the things to become more mindful of are the sexual arousal and desire systems. Okay, now I'm ready to move on to the next section. And I just wanted to start out by just kind of giving us a lay of the land. But now I really want to get into the clinical aspects of the illness. There's a difficulty which is called sexual anorexia. And it's fairly wide known in the field of sexual compulsivity. And what you find is that individuals who are hypersexual sometimes become hyposexual. That is that once you get their hypersexuality under control, then they become low in their sexual desire. And the major reason for that is fairly obvious, which is that sexual compulsivity is an intimacy disorder. And it means that a person turns themselves and their partner into objects and are sort of fucking rather than making love. And in that, they are sort of masturbating with their partner. And so once you begin to help them get back in their bodies, less dissociated, more mindful, they end up being terrified of their partner. And so we've seen individuals who are highly sexually compulsive, you know, once they become less dissociated, they become terrified and have panic attacks when they're making love with a potential partner, and that moves them into sexual anorexia. And so over-control leads to out-of-control with regards to food. Over-control leads to out-of-control with regards to sex. And so oftentimes when people are doing diagnostic issues with this, they wonder if the client is hyposexual or hypersexual. Well, we find the majority of our clients have cycles of both, whereas at certain situations they may have low desire, in certain situations they have high desire. For example, we have clients who are married, and once they get under control of their anorexia, go into refeeding, they find themselves having sex with other partners. And lately we've been finding that we have a group here which is on sexual compulsivity. And I'd say 3/4 of the clients come and talk about sexual compulsivity, and they tell us things that they've never told their therapist before, which are that they've done things that they feel are shameful. So when they say that they're bad, and you're inferring that they think they're bad because of this or this or this, oftentimes in their mind, the back of their mind, when they say they're bad, it's because they have done things that they find are outside their own value system that they feel shameful about, and they are out of control. And the therapist doesn't ask, you're not going to get it. And oftentimes, even if you do ask, you're not going to get it because the client is so ashamed they're never going to tell you this. But you want to think of this as pathognomonic of the syndrome, which is that, oftentimes clients with eating disorders also have sexual disorders, and you really want to try to have a group available where people are talking about that, where it becomes normative to talk out loud about their sexual behavior. So when people are sexual anorexic, they have no interest or desire in their lover, and oftentimes the same people can find anonymous sex on the internet and be able to find themselves hypersexual. And in our experience, that's more common than not. Now, in the olden days, when I used to do sex therapy or marital therapy, and a person was having an affair of sorts, either on the internet or in actuality, I used to think of this as almost always reflective of something wrong with the relationship. Now, what is wrong with the relationship? Well, when you get married, oftentimes your partner will say, well, there's you, and there's me, and then there's the relationship now. There's 3 of us. But so often with women, that isn't true. There's me in the relationship, but with women, the you is missing. And it's as if the person doesn't have a sense of self, and they define themselves as an object or as Mrs. Harry Jones, and really don't have a strong sense of self and individuation of self. And so when you have an enmeshed relationship where one person is sort of symbiotic with the other, then obviously sexuality gets affected, and it's oftentimes hard to get turned on by somebody you're enmeshed with. So the quality of that relationship is not entitle the person to be able to be sexual. So what we oftentimes say is that for most people who have desire or arousal problems, if you look at their relationship, that the dynamics of the relationship are not such that they would allow a person to become aroused. To get sexually aroused, there needs to be 2 individuals together in a relationship, and all 3 of them need to be attended to. So in the years that have passed, we found ourselves focusing more on the individual's relationship with self so that we can get an I before there's a we. And so our emphasis is heavily on intrapsychic intimacy, which means intimacy within the individual. And so as of late, we've been focusing on the concept of developing a secure attachment with self and begin to facilitate self-individuation. I remember in the early years when I would see this happen, I'd be asking the person to begin to cognitively define themselves and, be able to define what's idiosyncratic and unique about them, and to go out and do things that make them happy, and, discover self in a variety of ways, learn how to be alone, all those behavioral activities. But rarely did that intervention prove to be effective. It kind of helped, like icing on the cake, but it really didn't get it because there was something structurally missing. And if you look at the client developmentally at ages 2, 4, 6, 8, 10, and 12, in those core years when self is being formed, many, many things didn't happen that needed to happen, that we could call neglect. And they end up having structural deficits. And so it turns out that as an adult, they can develop a false self, and you could help them become more false by, helping them define that they're good at swimming or they're good at soccer or whatever it is they're good at, which then increases the false self. But what we're trying to do is see the development of a real self, and that requires more what we've been calling in recent years parts work, allowing individuals to begin either through Gestalt work or psychodrama or varieties of intrapsychic therapies, even EMDR, to begin to define parts of self that are disowned and re-own those disowned parts of self and get to know them in some way. So during the second part of this webinar, I'm going to be talking to you about how to do these parts work and facilitate intrapsychic intimacy, which is necessary for sexual arousal. Moving on to the next slide. When I talk about parts, this always becomes sort of obtuse, so I thought I would just give you an example. This is an eating disorder client that I work with, and she wrote about her sexually compulsive self. She said, I make Judy is a name that I'm giving to her inner self. She would use her own name. It all starts out as a game. I need men to desire me, to see me as a sexual being. I need men to stare at me and want me. I want to be the sexiest in the room. It gets out of control, however, when a man pursues me because I do not know how to say no. I allow myself to be used sexually because it makes me feel good. I feel loved, adored, and liked. During sex, I pretend to be a fantasy and try to be everything the man wants. Many times I detach and watch. Later, I feel dirty, used, and shamed. This part of Judy demands to be emotionally detached and gets angry with a guy if he's needy. She just wants to be fucked, damn it, not loved. Just feel good by being an object, a fantasy. Sometimes she worries she isn't even good enough for this. Now, if you listen to the client here, really she says so much that really becomes the focus of therapy. First of all, she needs men to desire her. So for her, sexual desire and arousal is a way of being wanted and being desired. It has really very little to do with sexual arousal patterns. Oftentimes we'll see women here who hate sex, who are aversive to sex, but they want to dress in very sexual, provocative ways, and they want to be wanted, and they want men to want them, and then when men do want them, they feel repulsed. So there's kind of, you can think of that as contradictory parts of self. There's a part of self that wants to be wanted, and all of us want to be loved, but a part of us who's afraid and dismissive of attachment and afraid that men can hurt them. And so that's the first part that's in her line. Then second, it gets out of control because I don't know how to say no. Again, we find that as a very common problem among the eating disorder population, that they can't say no if you ask them, for a ride in their car, much less can they say no to a man who wants sex with them. And so they say yes to sex, and they become 100% focused on trying to please the man and trying to be, the world's best sex partner. And they are highly perfectionistic anyway, so they're really oriented in trying to be the perfect sexual partner for a man. Well, the man is sort of vulnerable at this stage, and he thinks maybe he's found his dream here, this person who wants to be sort of a piece of pornography for him, and may even start to enjoy that, and doesn't realize that there's no true intimacy in, pornography with pornography. And so it becomes emotionally unsatisfying and really dissatisfying to both. So it's kind of a trap, and that is very, very destructive to the relationship. And later you may see the man come in, and it may look like he's a real a person who's going to be very mean to women or controlling with women. And you don't see it as a two-part process where they've shaped the relationship in order to be able to create that situation, which both of them sort of fall into. And so it's really important at the beginning of a relationship to shape the relationship structurally for two people to be subjects rather than objects. And when that doesn't happen, you can have an incredibly destructive relationship. Anyway, you see this here played out where what she calls her part of self that's sexually compulsive, and there's another part of self that's highly sexually inhibited. And that's oftentimes what we find is that these parts of self are polarized inside. And so one part can want one thing and another part can want another thing, and they struggle inside, and they play themselves out in the bedroom in either choosing a man or in the activity with a man. But it's all re-victimizing, and all quickly sends them back into relapse because they find themselves in bed with somebody, waking up in the morning, hating themselves even more, and not really knowing why, because it could even be their husband. Okay, so turning to the next slide, what we try to do is help the person have greater sense of self. And this term is fairly esoteric, so I want to think about this out loud. Whenever the person has an empathetic relationship with self, it means that they're beginning to take their disowned parts, their young parts of self, their inner child, if you call it that, or inner children, and begin to have some appropriate empathy and compassion for what those parts of self have gone through. When that happens, there's a reparenting kind of phenomena that occurs, and there becomes a cognitive shift, whereas the person's able not only to be more empathetically attuned to themselves and to others, but they become in their body, they become more mindful of what's going on in their body, and at that point they're going to become much more aware of their sexual arousal patterns and even potentially their appetite patterns. And when they do, oftentimes, like we find with affect tolerance, they don't know what to do with the intensity of those emotions because they've never really felt them before. They've been numb all this time. And so they may need some real guidance in a way of just knowing how to handle sexual feelings. I don't know if you all remember what it was like around puberty when you first had that rush of hormones, but sometimes there's an intense feeling that accompanies puberty, and a lot of adolescents are confused. John Fowles, the author, once wrote that the way we treat sex in this culture is a lot like sending a person out to sea without a rudder. And we can just see the ship running around in circles without a rudder. And because there's so little guidance and so little what Fontaine would call reflective function. So reflective function means that when a person begins to experience proprioceptive arousal in their body, they need someone to talk to in order to be able to have those events be able to have some sort of labeling associated with it at a cognitive level. So at that point, having a female therapist is of great advantage because no man will ever know what it's like, obviously, to have their clitoris stimulated. And therefore, it's oftentimes worthwhile to have a female consult come in and work, if you're a male therapist, on beginning to, have some discussion about this. If you're not able to have that, then there are books that are particularly useful. This Lonnie Barbeck has written a number of books on sexual arousal and sexual desire that begins to put some labels to it so a person can begin to compare their experience. Also, simple reports like the height report. I don't know if anything's ever been written as good as the height report, even though it's probably out of print. But the height report really interviewed large numbers of women and had them talk about their sexual experience and sexual arousal patterns, and I never found anything as good as the height report in helping clients be able to do that. So I highly recommend it, although there might be more contemporary books written that I don't know about. Okay, so let's go back to working with eating disorder. As you know, there are enduring problematic patterns of feeling, thoughts, and motivation with your eating disorder population. One is perfectionism, high degree of competitiveness. Third is that dark emotion of envy, where a person comes in the room and is thinner than you, you find yourself comparing yourself to that person with a lot of anger and a lot of hostility in a destructive way. Typically, there's a high degree of situational generalized anxiety or social anxiety. Oftentimes there's a lot of guilt around the obsessiveness, and that got involved with the hand washing compulsions when they were younger and such. So you can expect that as soon as you start getting into sexual related materials, all these issues are going to get activated. One of the things that we do is we have clients work in the kiln, because when they work with mud in their hands and the gooey stuff, you can, in the middle of them, begin to use sexual kinds of imagery, and then they can see their hands in the goo, and they can begin to associate it. Or, for example, you can take certain creams and put it on your hand, and you can put it on one hand and then say, what if that was ejaculate? And the person would go, oh, that's disgusting. But after a while, they could begin to associate the two of them, because you can imagine a person who's highly guilt-ridden, obsessive, and oriented towards sensory. If they're going to get ejaculation, it's going to be something that's going to freak them out and disgust them. And so, here you are sending them back to be in relationships, and you haven't done work around ejaculation. Well, they're not going to tell you that I think the smell of ejaculation is horrible, but you can assume that if they're eating disorder and have these kinds of patterns, that's one of the things they're going to have to be able to deal with. So, if you're a good therapist, you're going to be bringing these things up and asking them, because they can barely say the word masturbation out loud, much less ejaculate. And you can say, well, where do you do that in therapy? Well, it depends. If you have them in a short-term program, then you may want to begin to bridge the gap in a sexuality group. If you have them in a long-term recovery program, then you want to let them know that you're the kind of person that can listen to this. And if you don't bridge the gap relatively quickly and talk about some of these factors, they're never going to bring it up to you, because they're going to think you can't handle it, or you're going to think that it's disgusting. So it's a pretty good idea to begin to talk about these things and really deal with them fairly straight on. But you can just imagine, competitiveness coming in, because what happens is they want to be perfect in bed. And if they're worried about their hair, or they're worried about their makeup, or they're worried about the person looking at their body because of their body dysmorphia, how can they possibly be involved with making love with another person? Sex becomes really about them, and either they're obsessed with their own body and therefore there's no room for the partner, or they're obsessed with pleasing the partner and there's no relational. So you want to begin to open up the frame of reference that sex is a relational kind of activity. One of the things that we do routinely at Castlewood is, if the person's in a committed relationship, we'll ask them to bring their partner in, and towards the end of therapy, what we're going to do is we're going to ask them to begin to move into sensate focus in the traditional Masters and Johnson model. If you remember Masters and Johnson, what they did is they'd send a couple home, and these were their instructions. I'd like you to go home tonight. I want you to take off your clothes. I want your partner to take off their clothes. I want you to have some light in the room. I want it to be comfortable in some ways. And I want you to touch your partner, breasts and genitals off limits, head to toe, front to back, in a sensual sort of way. By sensual, what I mean is I want you to be mindful of what you're taking in through your eyes and through your fingertips. I want you to feel their face. I want you to feel their hair. I want you to feel their body, their torso. I want you to feel their legs. I want you to feel their feet. And I want you to notice in a mindful sort of way what you're taking in through your fingertips. I want you to be able to put words to what you're experiencing. And tomorrow when you come into my office, I'm going to say, when you touched his face, what did it feel like? When you touched his hair, what did it feel like? When you touched his lips, what did it feel like? When you touched his rear end, what did it feel like? And by beginning to become more mindful and be aware of this, it just takes them and distracts them in a positive way. So instead of thinking about, is he looking at my body, or am I a good lover, what you're going to be doing is focusing instead on the other person and touching for oneself. The result of it is it becomes very, I don't know, it helps them become more sensually involved with the partner, and begins to kind of do what in the behavioral literature would be called an exposure. Because by exposing them to nudity in this way and helping them feel less anxious and more comfortable, the result of it is that they begin to really feel much less anxious, and they get a frame of reference of being able to make love with somebody rather than making love to or for somebody. So if you're making love to somebody or for somebody, then it's not very intimate. But if you're making love with somebody, it's incredibly intimate. And so you want to begin to give them some frame of reference, oftentimes for the first time in their life, what it's like to make love with another person. And that's the first phase of sensate focus. Well, with our clients, we tend to probably stay at that phase, because oftentimes they have a hard time taking their clothes off. They have a hard time putting the lights on in the room. They have a hard time not focusing on their body. And then, of course, a vast majority of our clients have trauma in their history. So what happens is that they, with trauma in their history, what happens is that they become triggered and go into flashback. So you have to begin to work with them on the flashback, and to be able to do more trauma resolution therapy before you're ready to move on sensate focus. Okay, so one of the key things that happens at that point is if they say that while I was touching my partner, a part of self jumped in, a child part of self, and thought it was disgusting, it's oftentimes a sign that they have not done proper trauma resolution work and they're highly dissociative. And if they're still dissociative, then probably sex therapy would be contraindicated, and you'd want to do this later on after you've been able to complete the trauma work. So what we do is we tend to use the CAPS here, way of measuring PTSD. And when the CAPS score is high and we're able to get it down to low, then we feel like we've treated the post-traumatic stress effectively. We wouldn't necessarily start on the sex therapy until the post-traumatic stress is effectively treated. But on the inverse of that, there are many people who think that, treating PTSD is sufficient. But PTSD is only one phase of the treatment, and following that, working on intimacy, relationship, sexuality, and attachment are really key elements of the work. Okay, so this next slide is that sexual desire for some of our clients who are highly anxious is very anxiety-driven. It's the desire to conquer the other, to somehow be able to have the other desire or want them. It's in order to feel continually accepted. The individual is driven to compulsively seek affirmation of their acceptability because of their self-hatred. So hypersexual individuals sort of are starving for attention, affection, touch, and validation, and don't know how to get those needs met directly. So the only way they can know that they're desired is if somebody wants to screw them. And, of course, that turns out to be contraindicated. So we have clients here who really have no relationship with self, who are anorexic, who are meshed with their families, and the only real intimacy they have is by finding guys to have sex with them. And they don't really enjoy the sex, but they enjoy somebody loving them and they enjoy the intimacy of it. So you can imagine that what we're talking about here is beginning to teach people not only to be intimate with themselves, but how to begin to be intimate with others and how to get their needs for affection met by other people. It could be through touch, it could be through holding, it could be through kissing, it could be through talking, but intimacy is sharing your innermost self. It's the privilege of a committed relationship to be vulnerable. And so teaching them how to be vulnerable with other people is really a key element. And what we find is that, if they can be vulnerable here at Castlewood, we would think that they'd be able to generalize that out and be vulnerable with friends and with lovers when they leave here. But that does not generalize out in our experience. We find that we actually have to bring the partner in and have them practice vulnerability as a two-way street and help their partner be vulnerable and help them be vulnerable in a couple kind of session, and begin to structurally work with that, because what they learn with people here doesn't seem to generalize itself out. Same thing in the bedroom, that the best lovemaking in the bedroom is when you can laugh and talk, and that sex is much more than penis and vagina, but that it has to do with two people kissing, and kissing being as wonderful as penis and vagina, or if there's same-sex arousal, vulva with vulva or penis with penis. But the idea then is that to teach them the delights of sensuality. And if you can imagine, if they can't enjoy a cherry pie, can they really enjoy somebody touching them on their face? So what happens is that they feel, when someone touches them on the face, numb. They feel like they don't feel anything. And it's a little bit like, well, if you touched a blackboard and you'd say, well, the blackboard doesn't do much for me. Well, that's what they experience with that. And you say, well, what do you do when somebody is that? And the next slide sort of gets to that, which is that that's an indicator that they're dissociative. And dissociative means that they're not able to integrate sensual experience. And that, there's only one reason why a person can't integrate sensual experience, which is they are filled with anxiety that is of such great proportions that they don't even label it as anxiety. And the eating disorder facilitates that. It allows you to bypass, to override, and to transcend. It puts you in control. It binds your anxiety. So while you have this eating disorder and it binds your anxiety, you can make love with a partner sometimes. But as soon as you give up your eating disorder, as soon as you go into remission and you leave your eating disorder on the side, then suddenly you begin to feel, you're in your body, and suddenly your anxiety. So even if you could make love with your partner before you came into therapy, you're going to have difficulty making love with your partner after therapy. So the partner's not going to be really happy about that, and they may say, God, I feel like I'm getting worse rather than getting better. And therefore, it's good to give them anticipatory guidance that it makes perfect sense that you're going to get worse, because if you're in your body and you're feeling, you're going to feel terror. And all those things that you use your eating disorder to bypass in some way. So now, all of a sudden, you are in your body and you're feeling. Now, what's the treatment for that? Well, the treatment for that is the same with the eating disorder. It's exposure therapy. And exposure therapy is sensate focus, exposure to a partner, allow yourself to be sensibly touched, and to practice being in your body and feeling it. But you can't do it if you don't physically. You can't do that with a client sitting in your office in a 1-hour session with you and the client. You have to bring a partner in and help them begin to do that with a partner, or else give them homework assignments to try out with a partner where they can come in and talk to you about it in some way. Now this next slide is, I think, a particularly important one, which is, I don't know if you can see it, but if you look, what you notice is that she has what we call dead eyes. And dead eyes are an indicator of dissociation. It's oftentimes the form of disorganized attachment that you see. And so she's with him, but she's not really. And this so often happens with our clients. You know, their false self is great, and they can be with other people, and they can be really social, they can be delightful, but they feel alone when they're with other people. They feel alone when they're in crowds, and they feel alone when they're with their lover. And you can see this in her eyes in some ways. And this is a person who's very disengaged from themselves. As much as I've worked on this pattern in sex therapy, you know, I spent almost 15 years working with Masters and Johnson trying to work with these kinds of disorders. What I found was that everything I was doing was necessary but not sufficient. And that's the second part of my career. I work with trauma because, you know, most women have complex trauma. They have something in their background where they have been injured and hurt by a man. It's fairly endemic in our culture. Sometimes they remember it and sometimes they don't. And that's the problem. And so what happens is they feel like there's something wrong with them. They feel like they're defective. They feel like they're bad, and they hate themselves because this man on the left obviously adores her, but she can't reciprocate, and she doesn't really know why because he's such a terrific guy. This kind of woman, I found over time, maybe married for a long period of time, you know, just become an object, use KY jelly in the bedroom and open up her legs and have horrible sex. And then she'll find herself at work, and there'll be some bastard at work who will be mean to her and nasty, and she'll find herself incredibly sexually aroused by him and able to have really passionate sex with a stranger. And that's what we call a trauma bond. A trauma bond means that there's something from the past that's intruding in the present, and the person goes into flashback. And one of the aspects of a trauma bond is what we call reenactment. So if a woman is in this state where she has dead eyes, it's always a reenactment. It's always a repetition. It's always unfinished business from the past. And no matter how much relationship therapy you're going to do with her, you're not going to do it by working with a couple. You're going to have to go back and find out what part of her is stuck in the past and help her finish whatever it is that she's stuck in a complex trauma model, and have her reassociate that so that she doesn't go into the dead eyes. And that happens also, you'll find that the variety of things that come into her head as she intrudes into consciousness. Sometimes she'll, with body dysmorphic disorder, they'll begin to imagine themselves having, you know, a different body than the ones they have. And it almost seems like they're psychotic, where they can look in the mirror and the image they see is not there. I had one client who said, you know, today I looked in the mirror and I saw myself for the first time. And I said, tell me what you mean by that. She said, well, when I was a child, I was overweight, and every time I looked in the mirror, I saw myself as overweight. And when I looked in the mirror today, I saw myself as I really am, not overweight. And I said, oh my God, you know, your eyes were hijacked. And you know, what could be a more pure dissociative experience than that? What allowed her to begin to see herself accurately was she had to find the part of self that had hijacked her eyes, who was really frozen in what Roland Summit called encapsulation. In encapsulation, they were frozen in a bubble over time and really left there like in frozen state. As we went in the bubble and began to work with her on what happened to her when she was an adolescent and unfreeze that bubble, that part was able to integrate with her, and the result was she was able to get through the body dysmorphic disorder. But as you all know, body dysmorphic disorder is one of the most difficult problems to treat. There are workbooks on how to treat it. I have not found them to be terribly effective because I believe that body dysmorphic disorder is a dissociative disorder, And none of those workbooks take into account the dissociative nature of body dysmorphic disorder. But what could be more body dysmorphic and dissociative than a person looking in the mirror and not seeing the image that's in there? Now, this next picture begins to move into what you might call pornography. The difference is that they seem to really love each other or care for each other somewhat, but if you thought of this woman as a prostitute, you might think differently. Anyway, the point of this image is that we're talking about passion, and there's more to sex than just copulating. There has to be passion. And so one of the things that we find is that you've got to break passion out and begin to deal with it outside the bedroom before you can deal with it in the inside the bedroom. Like, you know, there's that wonderful movie about the story about what does it taste like to eat a peach. I don't know if you remember that part of, I forget the movie in time, that what does a peach taste like if you had to put words to it? And is a peach delicious? Why is a peach delicious? Well, if you don't know that a peach is delicious and you can't mindfully experience a peach, you know, can you experience passion? And if you can experience passion, you know, can you experience it? So what happens is you need more and more to get aroused. If a simple kiss is not passionate for you, if it's numbing for you, then you may need to be hit against your head against the floor and pounded or blood coming out in order to be able to feel anything. And that's not uncommon with our clients, where they'll say that they've never had sex that wasn't violent, even on the first date, because in order to feel anything, they've got to conk themselves in the head or create blood or hurt themselves in some way because they're so damn numb. So what you want to be able to do is go back to the peach and begin to have a sensual experience with a peach and learn how to be able to be mindful with a peach in order to be able to discover their passion. So I'm really big on helping them begin in part of their recovery is discover the passion for life and living, not with false self, like, you know, I have to go to Jamaica or go to Rome in order to have a good time, but how to have fun and how to play and how to be sensual in their own backyard. And as they're able to do that with themselves, then it becomes more delicious to do it with a partner. And if you need to have more and more, now obviously it's not just the eating disorder client who has this problem. We have a whole cultural problem of people becoming bored. And I think passion may be the problem of our culture. Our culture needs, you know, to buy more and more stuff and work harder in order to buy more and more stuff in order to be able to feel anything, because they already got a new BMW and that's always boring to them, and they need more in order to be able to get that hit. And so what we need is this mindfulness revolution where people begin to get back to basics and be able to get back in their bodies and be able to get back to feeling in a more sensual sort of way. So you can imagine that you just can't take sex out of the context of sex. You really want to work with them on passion. So I want to say something about this, and then I'll finish up for the day, and we'll continue more next time because I want to leave some time for questions. But so often the sexy woman in our culture is a woman that intimidates because it's woman as an object rather than as a subject. You know, if you said, what's a sexy woman? You know, she comes in with a red dress on, you know, her breasts are showing, you know, she is got this look on her face that, you know, somehow means that she's desirous of pleasure. She likes to evoke every head turn in the room. Her power resides in being wanted and needed by other people, and she puts a lot of time into her makeup in the morning in order to look sensual and desirable, you know, but then resents it that, you know, men look at her like they want her. So it's a weird kind of contradiction that we have in our culture, and it's culturally deprived. So, you know, our eating disorder clients are obviously subject to this, and they get caught because they have gender identity problems much greater than the general population. They get caught in the cultural problem magnified times 10. And so they're so confused about, you know, what to look like and what they want. And so you really have to begin to address this area, because once they get under control of their eating disorders, it's very, very common to turn to these sexual desire or arousal problems that we're talking about, or to go the other direction and be totally sexually inhibited, and they find themselves, you know, not dating. We have IOP here at Castlewood, and there are 20 women in IOP, and I'll bet you that, you know, other than the ones who are married, none of them are dating. And so you know, you've got to have a relationship with an I before you can have a relationship with we, but eventually you need to have a relationship with we. But they're so afraid of their own power with men and their own inability to say no with men that it's very difficult. So part of recovery is beginning to cross this line and begin to teach them how to be a subject with a partner. And, you know, we find that rehearsal is one of the best ways to do this, using men on our staff to be able to do social skills and be able to deal with social anxiety and use dating skills becomes incredibly helpful in helping them practice these situations and rehearse them, which becomes incredibly important. Okay, I know I've talked a lot and I've said a lot, so I think at this point it's probably a good idea for us to step back and just see if there's any questions, either from people in the room or from people out there. And if you like this and you find it interesting, come to part 2, because I'll get much more into part 2, what we do with the therapy and how to help a person have a relationship with self in part 2. Questions?
And so if you are joining us on the webinar, the way you do questions is you have a question feature on your webinar screen, and you can just type in your question, and I will read it to Dr. Schwartz.
I'm going to be typing them into my computer here, if you're wondering.
And Mark, can you hear me?
While we're waiting for a question from the computer, anybody in the room have a question? You know what I mean? Answer, that's the answer. If somebody's sexually compulsive, typically you want them to sign an abstinence contract for a period of time in order to practice that. But how long that period of time is depends upon the client and their problem. It could be as little as a week or a month, just, you know, like to go cold turkey and find out what it's like. For others, it's a much longer abstinence contract. And particularly when they're coming out of the eating disorder, you know, their compulsive sexual behavior is going to take them right back to the eating disorder. So it's better that they work on their relationship with themselves at least for 3 to 6 months before we would begin to have them look for a partner. But after 3 to 6 months, I think we have to begin to bridge partner relationships, because that's going to quickly send them back to relapse, either being so damn lonely and not having anybody, or, you know, the idea of going back to sex takes them back to eating disorder and their obsessions with their own body. Any questions from the group? Nothing's coming up. Is there anything else in the room? I feel like a radio announcer here. Anybody? Shame and masturbation, how do you handle it? Well, the best way is to be able to say the word. You know, in group I talk about masturbation, and all the women in the room sort of look at me like I'm half nuts. But the fact that they can hear me say the word helps desensitize in some ways. And I say it, and I'm so comfortable with saying it that they don't get freaked out. And I don't turn it back to them and, you know, say, you know, anything. I just sort of talk about it like I'm talking about a trip to Jamaica. So the more comfortable I'm with it, the more they are. And what I would say is, you know, something like the statistics that I gave. You know, most women masturbate, and most women learn to masturbate, you know, before their adolescent years. You know, a good 75 to 80% of our culture, it's normative. Have you ever learned to masturbate? If not, is it something you're curious about? And do you have any kind of things that have happened to you in the past that would make you uncomfortable with it? And, you know, would you be open or willing to learn about it in some ways? I also show them films. I have a film of women learning to masturbate, and I show them, you know, 5-minute clips of that film. And as they get exposed to it, obviously it's voluntary, and they can come if they want or not if they don't. We talk about it, but we do it in really small segments. And, you know, the women learn to touch themselves in sensual ways, and masturbation is a part of that. So, you know, I'm a sex therapist, so I just go right to it and begin to talk about it fairly directly. and that seems to be the best way. So what the person in the room is saying is that sometimes a client here will have as much shame about putting food in their mouth as they would a penis in their mouth, and talking about masturbation. And that what one has to do is begin to talk about that in group and desensitize that in a very same kind of way as we're talking about this today. So, you know, you're doing this work all the time around food-related issues is the point. And so, you know, doing it with regards to sex just becomes a natural subset of that. When memory is not available and you have trauma issues, usually the best way to go into it is through the problem that comes up. So if you're talking about masturbation and the person find themselves very triggered by masturbation, then you're going to have a door into what happened to them. And so, you know, you have them begin to look back and try to figure out what it is that the cue of masturbation activates from the past. And oftentimes, as they begin to follow that, it's like a door or a window. It'll lead them back to events that have occurred in their life that might have shaped it in some ways. And there are events that seem sort of irrelevant in some ways. Like there might have been a time, for example, when they walked in the bathroom while somebody was in the bathroom, and that they hadn't coded that as traumatic. But for a lot of our clients, they're so sensitive and highly reactive that things that can be relatively neutral to the rest of the population might be very traumatic to them. They might be very sensitive or reactive at a certain stage. So I find that some relatively normative events can be incredibly triggering to people with regards to sexuality. How do you bring somebody back into the body when they're in a dissociative state? Well, that's a good question, because the first stage of treatment is always grounding and containment. And grounding has to do with beginning to help a person get into their body in a mindful way. We sometimes will start with them by just, you know, like throwing the ball with them and beginning to be in their body while we're throwing a ball with them, moving their body in a variety of ways. And then we'll teach them how to begin to ground themselves with objects or with words. I oftentimes give my client a rock that comes from a big rock in my office, and it kind of becomes an object that they can rub, and it reminds them of the relationship with me and also grounds them and contains them in some ways. And so they know they're in the present, they know they're in safe, they know they're at Castlewood, and they know nobody's going to hurt them when they're touching the rock, and they can feel that connection with me, which helps ground them. So grounding and containment in a variety of ways is necessary if they're leaving their body. If they're dissociative with regards to the food, then the same thing's true. A lot of our work is at the table, getting them to come back and be in their bodies at the table because they dissociate at the table. So very similarly, having objects that can ground them, having name tags that remind them, having pictures of their children, having, you know, other kinds of things that bring them back to the present rather than being in the past, and then practicing that. Oftentimes we'll sit down and do one-to-one behavioral therapy with them, and we'll teach them how to go away, bring them back, go away, come back, go away, come back. And it's a skill that you get good at, and you must get good at if you're going to do outpatient therapy with dissociative clients. You have to learn how to take it out, put it away. Yeah. The whole next part of the series is going to be on attachment and eating disorders and sexuality, because you're absolutely right in asking that question, because what I find is that the sexual problem always mirrors the attachment problem. And if you don't treat the attachment problem, then you're going to be out of luck in dealing with the sexual problem. It took me 25 years to figure that out, and it's going to take you till next week to be able to find out what I've discovered. So eating disorder is one of those fields that there are not many sexual specialists in, unfortunately. And I think that's one of the reasons why I wanted to give this webinar. Yeah, I mean, I think that's a sign that you're needed. And if you talk about sex and the person's getting triggered, then obviously they need your help. So you've got to start wherever you can start. And typically, you know, a person like that has too many taboos too early, and I would say, you know, 100% probability of some trauma occurring in their past around sexuality. So you want to begin to talk about the trauma. If they're not willing to talk about the trauma, then oftentimes I put them in a group, and where other people are talking about trauma. And usually in that group, they'll hear other people talk about it, they hear other people get better, and they'll say, I think I need to do this too. And their peers work with them one-on-one with this, and it's remarkably helpful. So I wouldn't really think about working with a person one-on-one without having a group to be able to back me up, because the group can do things that I can't do as an individual therapist. Okay, it's a good point for us to stop, and I want to just thank you all for coming. And if you have any feedback from me before next week, you might just email me at mfs96@aol.com.
Thank you so much, and have a great day.